respected heads of departments of both the Department of Medical Education as well as Department of Health Services. The moderator of today's session, Sukumaran sir, all the senior leaders of Indian Academy of Pediatrics. I can see Anandakrishnan sir, Joe sir, and our secretary, Dr. Gobi is here, Dr. Binukutan, our treasurer is here, and the distinguished faculty for the day, Dr. Bindusha, Dr. Jijo, and Dr. Krishna Mohan, and all my friends here from Indian Academy of Pediatrics as well as from the Medical Education, Health Services, and National Health Mission. Dr. Rahul also has agreed to join. I think he will be joining soon. And Meenakshi Madam, our additional Director for Health Services, is also expected to join the meeting. So all of us know why we have...
Dr. Yes, I am there.
Madam is here. Okay, welcome, Madam. Welcome.
Thank you.
Okay, Madam. Welcome. So, we all know why we arranged this very important meeting on an emergency basis, because we were all pained by hearing deaths of children in different parts of the country, and it was told that it was because of the consumption of some cough syrup. With the available information, we all know that it was not the drug molecule which was the villain, but the compound or the chemical which was used for the solvent preparation was the villain. But in these circumstances, the central government has given some directives which actually gives a blanket ban of cough remedies in children less than 2 years. And it has created a panic among not only parents, but also among pediatricians and other doctors. So we need to have a very clear guideline how to treat children with cough. We need to treat children with cough. We cannot tell them that we are helpless or anything, but we should follow the scientific principles and the law of the land. So we have arranged this particular meeting, and we have experts, and the panel is headed by none other than Sukumaran sir, who is the doyen of pediatric respiratory medicine in our country. Sir has vast experience in the field, and along with him we have the panelist as Dr. Bindusha, who is Professor of Pediatrics at Government Medical College Trivandrum, Dr. Jijo Joseph, who is HOD of Pediatrics at Believers Medical College Tiruvalla, as well as Dr. Krishna Mohan, who was also the chairman of respiratory allergy chapter, and also he is a senior consultant pediatrician in health services. So we have taken people from all the sectors, and this is a session for all of you. We after the panel discussion, we can also answer any questions you have. You can just type in the questions in the chat box. So now I invite our most respected Director of Health Services, Reena Madam, to address the gathering.
എല്ലാവർക്കും നമസ്കാരം. ഇത് നമ്മൾ ഈ ഒരു മീറ്റിംഗ് ഇപ്പോ എമർജൻസി ഉദ്ദേശ ലക്ഷ്യങ്ങളെ കുറിച്ച് ഡോക്ടർ റിയാസ് ഓൾറെഡി പറഞ്ഞു കഴിഞ്ഞിട്ടുണ്ട്. അപ്പോ ഇങ്ങനെ ഒരു ഓർഡർ സെൻട്രൽ ഗവൺമെന്റ് എന്ന് വന്നതിനെ തുടർന്ന് ലെവൽ മീറ്റിംഗ് മിനിസ്റ്റർ തന്നെ വിളിച്ചു കൂട്ടുകയുണ്ടായി. ആ വിളിച്ചു കൂട്ടിയ മീറ്റിംഗിൽ എടുത്ത ഒരു തീരുമാനപ്രകാരമാണ് ഇന്നത്തെ ഒരു മീറ്റിംഗ്. അപ്പോൾ ശരിക്കും നമ്മൾക്ക് സപ്രസന്റ് ആണോ ഒഴിവാക്കിയത്, എക്സ്പെക്ടന്റ് ആണോ ഒഴിവാക്കിയത് എന്നെല്ലാം വളരെയധികം സംശയങ്ങളുള്ള ഒരു സാഹചര്യമാണ്. അപ്പോ വളരെ എക്സ്പീരിയൻസ്ഡ് ആയിട്ടുള്ള സീനിയേഴ്സ് അടക്കുന്ന അനന്തകേശവൻ സാറിനെയൊക്കെ കാണാം, എന്റെ സാറാണ്. അവരൊക്കെ ഉള്ള ഒരു ഇതിൽ വെച്ചിട്ട് നമ്മൾക്ക് ഒരു ഇതിന് ശാസ്ത്രീയമായ വിധത്തിൽ തന്നെയുള്ള ഒരു കഫ് റിലീഫിന് എങ്ങനെ ചികിത്സിക്കണം എന്നുള്ള ഒരു ഗൈഡ് ലൈൻ ഉണ്ടാക്കുക എന്നുള്ള വിധത്തിലാണ് നമ്മൾക്ക് നിർദ്ദേശം ലഭിച്ചിട്ടുള്ളത്. അപ്പോ എല്ലാവരുടെ വിലയേറിയ ഒരു ഡിസ്കഷനും അതിൽ നിന്ന് ഉരുത്തിരിഞ്ഞു വരുന്ന ഒരു ഡീറ്റെയിൽഡ് ആയിട്ടുള്ള ഒരു ഗൈഡ് ലൈൻസ് നമ്മൾക്ക് അപ്രൂവ് ചെയ്യാൻ പറ്റുമായിരിക്കും എന്നുള്ള വിശ്വാസമുണ്ട്. അപ്പോ സുകുമാരൻ സാറിന്, അതുപോലെ തന്നെ ബിന്ദുഷ മാഡം, കൃഷ്ണമോഹൻ സാർ, എല്ലാവരും ഈ ഒരു വേളയിൽ നന്ദി പറയുന്നു. താങ്ക് യു. പ്രോഗ്രാം നന്നായി നടക്കട്ടെ.
Thank you very much, madam. Now, I am very glad to invite my own teacher and Director of Medical Education, Vishwanathan sir, to address the gathering.
Good evening and thank you, Dr. Riaz, all the senior faculty, respected teachers, colleagues from the Department of Pediatrics, and the members of the Indian Association of Pediatrics Kerala chapter. It is indeed, I am seeing about 150 plus participants, around 150 participants as of now. That shows the curiosity and the concern that has been generated by the recent events, especially with, as Dr. Riaz rightly pointed out, with the death of so many young children for no reason, no cause of theirs, that they have suffered this major fatality. It's indeed also shocking. It was a shocking news for us, and as our DHS rightly pointed out, we had a close meeting of the senior administrators, and the government took a stand that we should get the opinion of the Indian Association of Pediatrics before they come out with a uh, proper guideline or whatever has to be done in this regard. However, there was a initial concern and controversy because the government of India also gave a blanket this one that no children should be given cough syrup. So that has generated lot of concern among the public, and also it has caused concern among the pediatricians because if they prescribe, we were also worried. Today's recent incident where one of the doctors has been assaulted in Tamarasheri for amoebic encephalitis death, which is also no fault of his. So we are the greatest concern is that how our doctors are going to be attacked or going to be questioned in this situation because the government of India has come with a directory. The drugs controller also because he has to follow the guidelines of the directory of the government of India that also came up. So I think that is the reason why the minister, honorable minister, mentioned that we should have a proper guideline. So the initiative taken by the office bearers of the IAP and all the other members of this association. It is indeed a welcome decision, and I hope that at the end of this deliberation we will be able to give a clear picture, and based on which the government can also come out with proper guidelines. So over to you, Dr. Riaz, and wishing that this will be a very successful deliberation. Over to you, Dr. Riaz.
Thank you, sir.
Yes.
So I acknowledge the presence of our past National Vice President Anandakeshwan sir, our incoming President Nandakumar sir, and all the leaders here. So, Meenakshi madam, do you want to add anything, ma'am? Or shall we go to the scientific? Madam, unmute.
So,
Okay.
I'm also very glad to be part of this meeting. This is the need of the hour because the blanket ban order from the central government is not at all acceptable, and also the drugs controllers order that also need to be revised. So we have to have a clear-cut guideline or something fruitful from this meeting, and we need to address both these issues. So I'm also really thankful to the IAP and the all the relevant members. Thank you.
Thank you, madam. So now I invite Dr. Binukutan, our treasurer, to introduce. There is actually no need for introduction, but it is customary to introduce the moderator. So to introduce Sukumaran sir and start the scientific session. Over to Binukutan.
Oh, thank you, Ria sir. Like Ria sir said, there is no need to introduce Sukumaran sir. Sir is undoubtedly the best pediatric pulmonologist in the country. Sir is our past national president in 2011. Sir got the Best Doctor Award from the Kerala government and the Best Doctor Award from the World Malayali Council. Sir is a former professor and HOD at Medical College Kottayam and Pushpagiri Medical College. Now, Sir is working as the senior pediatrician at Caritas Hospital. Sir is having vast experience, over more than 40 years of experience. So, to lead this expert panel, Sir is the best person to lead this expert panel. So, over to you, sir. Thank you.
Okay. Independent, am I audible?
Yes,
Yeah,
sir. Yes, sir.
Okay. Beloved chairperson, my close friend and the most dynamic president of IAP Kerala, Dr. Riaz, dignitaries, Dr. Vishwanathan, DME of Kerala, Dr. Reena, DHS of Kerala, Dr. Meenakshi, other senior members of the academy, my beloved friends and students. It gives me great pleasure and privilege to be here with you to participate in this webinar organized by Indian Academy of Pediatrics. As Dr. Riaz has correctly mentioned, we are going through a lot of problems in the management of cough now. Cough is the commonest respiratory symptom that we face. Initially, I want to say that cough is only a symptom and not a diagnosis. And for treating cough, the government of India has prepared an order saying that cough syrups should not be given for children less than 2 months. See, the treatment of cough mainly depends on the etiology of cough, and the treatment of choice also depends on the type of cough. For example, if a child is presenting with an upper respiratory infection due to allergic rhinitis, or the drug of choice may be an antihistamine. And if a child is having presenting with asthma, wheezing, the cough remedy of choice, I said remedy, not cough syrup, cough remedy of choice may be a bronchodilator. The bronchodilator as MDI or inhaler, the cough will subside. So it is very important that the pediatrician should take a very detailed history, examine the patient and make a diagnosis and start specific drugs for treatment of fever. But fortunately or unfortunately, nearly more than 22 children died in Madhya Pradesh and Rajasthan following ingestion of cough syrups. Most probably these cough syrups contain some of the toxicants like ethylene glycol, diethylene glycol, which can produce renal problem. And way back in 2022 also, nearly 65 children died in some of the African countries, and also Uzbekistan. Nearly 65 children died due to the complications of ethylene glycol and diethylene glycol. So it is very, very important that we should select the correct drug for a correct diagnosis. So cough syrup is not a treatment for all coughs. So you must select the correct drug for the correct diagnosis. So it is very important that you must take a detailed history. And regarding common drugs like antihistamines, in children less than 2 years, there is no problem in giving a second generation antihistamine. About 6 months, you can give a second generation antihistamines for cough and cold. I think there is no problem. And in older children, the first generation the syrups containing first generation cephalosporin like chlorpheniramine maleate and chlorpheniramine maleate should not be given for children less than 4 years because of the main side effects. Now we are going to discuss all these problems, how to make a diagnosis and how to treat this child with specific drugs. So for this seminar, we have 3 panelists, and Dr. Riaz has already introduced the panelists. Dr. Bindusha S., who is an excellent pediatric pulmonologist and professor of pediatrics from SAT Hospital, Trivandrum. Dr. Krishna Mohan R., who is working in health service. He is a very good pulmonologist, allergologist, and very good academician. I'm happy to welcome Krishna Mohan also. And last person is again the tallest man, Dr. Jijo Joseph John, who is an excellent teacher, very good pediatric pulmonologist, intensivist, and bronchoscopist, and allergologist, who is a professor and HOD of pediatrics from Believers Church Medical College. Welcome, Dr. Jijo Joseph. Now, we have prepared few questions and we'll start asking the questions now. Bindusha, please show the questions. So the first question is to Dr. Bindusha. Yeah, before you start treating a child, and you must know what is the mechanism of cough in a child. Dr. Bindusha, what is the mechanism of cough? All the panelists should be very short and crisp.
Thank you,
Bindusha,
sir.
please.
Cough even though it is a symptom of a lot of respiratory diseases and even some non-respiratory diseases, it's actually a natural defense mechanism of the respiratory tract. We cough to protect our respiratory tract and to clear our airway secretions. So if the child is not able to cough, the child can develop a lot of respiratory infection. We do see that the children with neuromuscular diseases develop a lot of pneumonia. Why? Because they are not able to clear the secretions by coughing. So cough has actually 4 phases. The first phase is the receptorial phases. Here the cough receptors, they are widely distributed over the whole of the respiratory tract, both in the upper respiratory tract and also in the lower respiratory tract, and also in the ears and also paranasal sinuses and all. So whenever there is some irritation or our secretions are there in the respiratory tract, these receptors will be stimulated. Once these receptors are stimulated, the impulses will go through the afferent nerves, mainly the glossopharyngeal nerve and all, to the cough center, which is located in the brainstem, and the cough reflex is stimulated. The efferent is vagus nerve, and it will stimulate the respiratory muscles and also the larynx, so that the next phase will be starting. The next phase is a complete inspiration, a full inspiration, which is followed by a compressive phase where there is a exhalation, and also at the same time your larynx will be closing, so that the patient will have a forceful expiration, forceful explosive expiration, and whatever is there in the respiratory tract may be expelled and the secretions can be cleared. This is the basic mechanism of coughing.
Okay, thank you, Dr. Bindusha. Even though Bindusha said the cough is a protective mechanism, but sometimes if the cough is very intensive and troublesome, we have to suppress the cough. For example, a child with a whooping cough, the system will be, cough will be there, but we have to give a couple of substance in that situation. Now, coming to Dr. Krishna Mohan, cough may be due to an upper respiratory problem or a lower respiratory problem. Can you differentiate the cough between upper respiratory problem and lower respiratory?
Thank you, Sumaran sir. So, from the properly taken history and clinical examination and watching how the patient is responding to our medication, we will be able to get some clues regarding whether it is an upper airway or a lower airway cough. So, if you take the prototype of upper airway diseases, allergic rhinitis, and a lower airway diseases, asthma or a pneumonia, we can see that there are certain differentiating features in the quality of the cough, timing, and the associated symptoms. So when the quality of cough is considered, an upper airway disease is more like a dry or sometimes like a throat clearing type of cough, whereas a lower airway disease is more of a protective or wet type of cough. Sometimes it can even be spasmodic type of cough, like in pertussis. And regarding the timing, upper airway disease, the most important example is an allergic rhinitis or a viral infection, upper respiratory infection, where you get a postnasal drip, which will be worse at night or sometimes during the early morning. But whereas the lower airway disease, it is mostly often nocturnal or with exertion, like asthma. So the associated symptoms are more important, where in an allergic rhinitis like picture, we will get associated sneezing, throat irritation, nasal congestion, etc. Whereas in a lower airway, we will get the associated features like wheezing, chest tightness, dyspnea, etc. So response to therapy is another important feature which will help us to differentiate. So an upper airway disease like allergic rhinitis usually responds well with antihistamines alone or with nasal saline, or sometimes requires intranasal steroids, whereas a lower airway disease responds more to bronchodilators or inhaled corticosteroids. So these are the important differentiating features, sir.
Thank you, Dr. Krishna Mohan. Usually the upper airway disease will get a dry cough. For example, the classical example is allergic rhinitis, which usually responds to a second generation antihistamine. But a lower airway, the commonest cause may be asthma. In asthma, the main symptom is cough, persistent cough, which occurs in the early morning hours around 2 a.m., 3 a.m. But these children will respond to a bronchodilator. Next question, please. Bindusha, next question. Jijo, what is the main difference between productive and non-productive cough? When we discuss about cough, we usually discuss about productive and non-productive cough. It's a basic thing. Jijo?
Yes, sir. Thank you, sir, for the question. Before we move ahead, I just like to thank the IAP Kerala for organizing this and giving us an opportunity. Coming, like sir rightly said, cough is a defensive mechanism and cough is a natural process. There is no cough which a cough syrup can treat completely. It might help the child and the parents' journey, making them a little bit more comfortable. The cough has to go through the natural cause of the illness based on what your diagnosis, as per what KMI told, based on the history and examination. In simple terms, productive versus non-productive is kaba ulla choma, kaba illata kutti kutti ulla choma. So with your productive cough, it's also called as a wet cough versus a dry cough. The sputum secretion might is much more higher in your wet cough and it is absent in your non-productive cough. Common causes for productive cough is mostly your lower respiratory tract infections, mostly pneumonia and bronchitis, while irritation to your upper airway is what usually causes your viral upper infections or asthma or allergies for your non-productive or your dry cough. Typical features in a productive will have can have coughing up of mucus, or when we hear the child, we can feel there is a lot of secretions in the chest. While non-productive cough is more irritated and scratchy with less reliever on expectorants, or it might not relieve on any most of the syrups which we give. In your wet is why we call it wet is because children can't spit it out completely. Most of the viral infections will resolve with supportive care. In your management of a productive cough, you might try an expectorant in a bigger child, but understand hydration, physiotherapy, and antibiotics if a bacterial infection is suspected has a much more bigger role to play than the very small role which the expectorant might play. While in a non-productive cough, we strongly advise not to give any antitussives in children less than 2 years. If it is because of an allergic cough, like KM told earlier, we'll have to treat the cause and add INS or ICS or inhale medications as required. As it develops, usually it is a pneumonia, viral or bacterial, which starts off with a dry cough, which can go in progress to a productive cough, while non-productive cough is usually seen in a viral infection.
Thank you, Dr. Jijo. As Jijo has correctly said, in upper respiratory infections, this is mainly a dry cough, and they usually they respond to dextromethorphan or an antihistamine, they may respond. But it is very important to note that there are particular ages at which you can give a particular drug. For example, dextromethorphan cannot be given for children less than 2 years. It is indicated only in children about 2 years. But cough is a predominant symptom in an airway disease. For example, in asthma, cough is a predominant symptom. When compared to pneumonia, it's an alveolar disease, cough is not a predominant symptom. Thank you, Jijo. Next question is again to Dr. Bindusha. There are two types of cough. One we call as an acute cough, and second is chronic cough. What is the main difference between these two, and what are the etiological factors?
Usually, cough which is lasting for less than 4 weeks is considered as acute cough by most of the guidelines. Sometimes some British guidelines may also consider cough less than 3 weeks as acute cough. Actually, the differentiation between acute cough and chronic cough it's actually arbitrary. Usually, sometimes a cough which may start as acute may persist beyond 4 weeks and become a chronic cough also. The causes of acute cough, the most common cause that we see in children is viral upper respiratory tract infection, or which is otherwise known as common cold. It may also be due to the lower respiratory tract infection, including all the group where you have the typical type of cough, then bronchiolitis, pneumonia. Any lower respiratory tract infection will also have productive cough, as was explained earlier. Then there's some other thing known as upper airway cough syndrome, where it is otherwise known as postnasal drip, where the cough is actually due to the secretions which are dripping on the pharynx and irritating the pharynx, which is leading to the cough. Asthma flare-ups will also come to us with acute cough. Then allergic rhinitis. Even if there is only rhinitis, there is some irritation of the throat and tooth, and the child will be coughing. Acute foreign body inhalation will also have acute cough. So if the cough is persisting beyond 4 weeks and it is persisting, then we need to think about other causes which may produce a protracted infection or inflammation. Asthma is the most common cause where the child if the child is having persistent symptoms. Usually in asthma, we see recurrent symptoms. An episode of coughing and wheezing may come and then it may disappear and may come again. So in children, cough is the most predominant symptom of asthma. More than wheezing, cough is the most common symptom of asthma. Then tuberculosis should always be considered if the cough is persisting beyond 2 weeks, especially if it is associated with fever and also loss of weight. Then TB also, to be diagnosis of TB will be more likely. Then pertussis is also one thing where it may start as an acute cough and it will persist, can persist up to 3 months. Here also you have the typical paroxysms of the cough. And then foreign body inhalation, especially if the foreign body was not identified, a biological foreign body like a peanut and all is not identified, can persist as either a chronic or recurrent episodes of lower respiratory tract infection. Then another diagnosis, that is protracted bacterial bronchitis, should always be considered in a small child where wet cough is the most predominant symptom. Then other respiratory lung diseases like bronchitis and also cystic fibrosis and also congenital anomalies of the lung, which may also present to us as either chronic cough or recurrent episodes of cough. So these are the things that we need to think about in cases of chronic.
Thank you, Dr. Bindusha. That, as I have said before, there are multiple causes of cough in a child, for acute cough and also chronic cough. Multiple causes are there. So with a single drug, single cough remedy, you cannot treat cough. Cough, you must try to find out the etiological factor and you must treat the basic etiological factor. The commonest cause for acute cough may be a viral infection, for which no antibiotics are required. But for pneumonia, it starts with antibiotic. With pertussis, antibiotics are required. Cough with TB, anti-TB treatment. So the treatment is totally different. With a single cough suppressant or a cough remedy, you cannot treat cough. Next slide, please. Next slide. Okay. There are a lot of confusion now regarding. I said bronchodilators can be used for treatment of cough. So is it a cough syrup? Antihistamines can be used for treatment of upper airway infections, upper airway disease. For example, allergic rhinitis and postnasal drip. So what do you mean by cough syrup and what do you mean by cold mixture? What is in your mind?
Yes, sir. So that is a very controversial question, and the answer is also a little bit controversial for the last 1 week after the new order got released. So there are no definition available in majority of our standard textbook of what is a cough syrup. So this definition I took from one of the studies which that US FDA has quoted while they were banning the use of cough syrups less than 6 years. So the definition what they have given is any cough syrup is a medicated syrup specifically formulated to relieve cough containing one or more active ingredients. So the basic purpose is to suppress or expectorate cough. So it may be a mixture of antitussive or an expectorant either alone or together. So that is what a cough syrup is. Whereas a cold mixture is also something like is a multi-ingredient liquid preparation targeting the multiple cold symptoms. So it is basically aimed for the symptomatic like nasal congestion, nasal discharge, etc. So it is a big cocktail of combination of cough suppressant, expectorants, antihistamines, decongestants, and analgesics. So this is one area where majority of the irrational combinations occur also. We will be discussing that later. Bindusha madam, next slide. So regarding the regulatory status, so we are too much worried about the recent regulatory status which was implied in India, that is for less than 2 years. But if you see the US and UK guidelines, both the US FDA and the MHRA of UK, that is the Medicines and Healthcare Products Regulatory Agency, both of them have banned the use of the over-the-counter combination of cough syrups as well as the cold medications in less than 6 years. So they have banned it in less than 6 years. So here also, only now it came as a directive. Even before, majority of us were not using because of the adverse effects. So we'll be discussing that soon.
Yes, Krishna Mohan, I thought we should accept the proposal given by the DHS, saying that cough syrups should not be given for children less than 2 years. It's a very good suggestion. I also think so. Vidusha, next question. Jijo, can you mention a few irrational cough and cold combination available in the market? Jijo, please.
Yes, sir. Like KM rightly said, the definition of cold medication itself is irrational as per the definition. If you look at the data, Vidisha, can you just go further slightly? So, if you look at the definition, these are all pre the ban itself, where he had more than 1,300 cough and cold products available. Many of them were fixed drug combination, which parents can buy over the counter, and they are deemed irrational based on the rationality criteria. Why are they irrational? Is they have more than one antihistamine, there is a cough suppressant. They have more than 3 to 4 constituents. Like you combine an antihistamine with a cough suppressant, with an expectorant, with a decongestant, and even sometimes even paracetamol with combination with other antihistamines are also available. Few examples is a cough suppressant and an expectorant coming together as both have opposite actions. Two or more antihistamine with a decongestant and a bronchodilator and a mucolytic all into a single cough syrup like an Avial, which is supposed to help in all these conditions, which actually won't help in any of these conditions together. And many times you have banned or potentially harmful components sometimes be available in updated formulations. And one of the biggest problems is when you have opposing drugs and redundant drugs from the same class, it increases the risk of toxicity, unintentional overdose, and adverse effects. You have new companies coming in with newer syrups and newer molecules telling us based on these studies, this is helpful. But many times the studies will be underpowered and they won't be effective. These are the common examples which we can give in multiple antihistamines or a suppressive and expectorant is combined together, or when you have multiple things going together. You even have opioid antitussive and others, which many times are being used in adult more than in children. So these are all different combinations and permutations which are available in the market at this point, sir.
Thank you, Dr. Jijo. So our learning lesson should be, ideally you must use a single drug combination. Single drug should be used for treatment of cough rather than going for multiple drugs. That should be the ideal thing.
Yes, sir.
Okay. Next slide, please. Yes, Dr. Bindusha, what are the components of cough expectorant and cough suppressants? There are two things are there. One is an expectorant and another is a suppressant. The usual
We discussed
composition.
earlier, so expectorants are actually recommended for wet cough. When the patient is having wet cough with sputum production and the child is finding it difficult to expectorate the sputum, then the expectorants are prescribed. Most of the expectorants contain bronchodilators, usually salbutamol or terbutaline. It may also contain mucolytic agents which will liquefy the sputum. That is ambroxol, bromhexin, N-acetylcysteine. These are the usual mucolytics, and they may also contain secretion enhancers like guaifenesin. Guaifenesin will make a lot of secretions. So these are the usual components of the expectorants. Whereas the cough suppressants are recommended for dry irritant cough, and these drugs are actually aiming to suppress the cough. These drugs usually contain suppressants which may be centrally acting, peripherally acting, or both centrally and peripherally acting. Codeine was an age-old example for a cough suppressant which is no more being used. Dextromethorphan is another centrally acting cough suppressant. Noscapine is another one. Peripherally acting cough suppressants are Levodropropizine, benzonatate. They are peripherally acting, and chlorpyrifene is both centrally and peripherally acting cough suppressant. Along with these cough suppressants, antihistamines may also be included in the cough suppressant syrups. It may be chlorpheniramine maleate, diphenhydramine, bilastine, promethazine. Different types of antihistamines are added. But these are the two different types of syrups which need to be available. But as Dr. Jijo said, many of the expectorants available in the market may contain antihistamine also, and many of the cough suppressants may contain the other expectorants also. But these are the ones which we usually consider as expectorants and suppressants.
So most of the cough syrups available in the market the combination is totally irrational. Even the expectorants, Bindusha has said salbutamol and terbutaline, it is also having some expectorant effect and mucokinetic effect is there for the bronchodilators also. So it is ideally to use one drug as a cough remedy rather than a combination of all these steps. Yes, Bindusha. Yes. Okay. What are the other ingredients of cough syrup other than these expectorants what she is told?
Yeah, yes, sir.
and suppressant.
So a cough syrup, when we say a cough syrup, it is not the drug alone. It also contains something called the excipients. That is the other, there are active ingredients as well as the inactive ingredients. So the active ingredient is basically the drug. We also have some other components like the sweeteners, thickeners, flavors, colors, antimicrobials, buffers, etc., which form the syrup. This is not only applicable in a cough syrup, for all syrups, like even an antibiotic syrup, all these things are there. So the importance is that when it comes to the adverse effects, some of these components is liable to produce some adverse effects, not only the drug. So we have to think about that, especially when we discuss conditions like drug allergy. There are certain components or excipients in cough syrups which are notorious for causing drug allergy. For example, the colors, tartrazine and all are they're supposed to cause anaphylaxis in certain people. So that is the importance of excipients. So it is not the drug alone. We also have some other components in the cough syrups that we have to keep in mind.
Hey, Jijo, can you tell us something about the cough syrup tragedies? Lot of tragedies has occurred, even in US, then Gambia, then Uzbekistan. Can you say something about the 2022 tragedy?
Yes, sir. So, like sir rightly said, there have been multiple tragedies. Let's just focus on one, which was the biggest news recently, which was the Gambia before the Indian thing happened. What is eerily very similar to what has happened in India is over there also around 66 to 70 children died, much more higher number, by four different cough syrups of different molecules. But the common thing was a lethal contaminant, ethylene glycol and diethylene glycol, which again had a very similar presentation, causing acute kidney injury and that leading to death. All these were the syrups which were there, and following which the WHO confirmed that this is what has caused it. There was also traces of E. coli contamination which was found in some sample, again compounding to the health risk. So, with these tragedies happening multiple times, we need to have much more stringent drug safety and quality assurance in cough syrup production. And the manufacturers, the ones wherever the error is happening, that has to be addressed of utmost importance with and penalizing the people who have done the mistake also. That should be our way ahead, sir.
See, the US tragedy occurs as early as 1850, but they had interfered, and after that there was no tragedy there. But tragedies are going on in India. Even the tragedy that occurs in Gambia, the drug was prepared by four Indian companies. Four Indian companies was prepared. Next slide, please. Bindusha, what is the role of ethylene glycol and diethylene glycol, which is supposed to be the culprit now?
This ethylene glycol and diethylene glycol, they are toxic alcohols. They are actually industrial solvents, and is also it's there in the antifreeze which you use in the vehicles and all. These things are colorless liquids with a sweet taste. So the contamination is very likely, and accidental ingestion can also occur in children. There are a lot of literature on the toxic effect of these drugs, because this is a drug which this is a drug or compound. Actually, these are not drugs. These are compounds which people use for inebriation and also for suicidal attempt. So there are a lot of literature about what happens after this ingestion of these drugs. Now we will see why these drugs are present in the cough. How come these toxic molecules are present in the cough syrup? This is actually accidental contamination of actually glycerin or propylglycol or sorbitol. These are the diluents which are used in the cough syrups, which may be accidentally contaminated with these drugs if the quality control measures are not stringent. It said that around 1 to 2 ml per kg of the solution, it is actually lethal. So what will happen is that once the patient ingests this ethylene glycol or diethylene glycol, they are molecules with high osmolarity. And in the blood, it is actually acted upon by the alcohol dehydrogenase, and it is converted to other compounds which are also toxic. The ethylene glycol may be converted to glycolic acid and oxalic acid, whereas the diethylene glycol will be converted to 2-hydroxy-ethoxy acetaldehyde and 2-hydroxy-ethoxy acetic acid, and then diglycolic acid. So what we need to know is that all these toxic effects that we are seeing may be due to the original products, but more often it is actually due to the metabolic products, especially the glycolic acid, oxalic acid, and HEAA, diglycolic acid. All these are toxic. So patient can develop in the initial stage, patient can have inebriation, because just like the ingestion of alcohol, you will be inebriated. So initially the children may be inebriated. Then they, another thing we can notice that there will be osmolar graph, the osmolarity of the serum will be very high, and later on the patient will develop metabolic acidosis due to the glycolic acid and glycolic acid content. And then oxalic acid, what happens is this oxalic acid crystals will be deposited in the renal tubules, and it will lead on to acute tubular necrosis. That is why the renal failure is there in almost all the patients who have ingested these substances. Then these oxalate is actually deposited as the calcium oxalate. So that will result in hypocalcemia, and the patient will have all the symptoms of hypocalcemia because it is an acute hypocalcemia. Patient may have tetany, patient may have even seizures and also cardiac arrhythmias. Then other things which may be there in other toxic effects are ARDS, then cerebral edema can occur due to this high osmolality and also acidosis, then cardiac failure, hepatitis, pancreatitis, leading on to multi-organ dysfunction syndrome. So the treatment what they usually offer for this poisoning is treatment with either a compound known as fomepizole or even ethanol itself, that is alcohol itself, which may inhibit this alcohol dehydrogenase so that the production of these toxic byproducts will be reduced.
Thank you, Dr. Bindusha. Now we can see that almost all organs are affected, starting from kidney, brain, pancreas, hepatitis, everything is affected by these toxicants. Next question, please. Cam, what is the, most of the cough formulas contains antihistamines, either first generation or second generation. And what is the problem with first generation antihistamines?
Yes. So the majority of the first generation antihistamines, they will be having a lot of side effects, including drowsiness, fatigue, dry mouth, headache, and the abdominal side effects. But more important is how they affect the scholastic performance of the child. Next slide, please. So this is one study which has proved if you are using a first generation antihistamine for long term, they can very well cause the scholastic impairment. Like you can see in this picture, diphenhydramine compared with a placebo and a second generation antihistamines. So the composite learning score is definitely affected by when you are using a first generation antihistamine, because if it is a chronic cough which is lasting definitely more than 3 to 4 weeks, and we are using the antihistamine continuously, the first generation antihistamine continuously, it is liable to produce all these side effects, including the scholastic impairment. So that is why we are forced to, so the recommendations suggest using a second generation antihistamine, sir.
See, Krishna Mohan, another problem that we face is with the second generation antihistamine is seizure. See, in those children with a history of seizure, a seizure disorder, if you prescribe an antihistamine, there is a chance of a recurrence of seizure in these children. And I have seen that most of the children with febrile seizure admitted in our ward, in the age group of 6 months to 6 years, most of the children has received first generation antihistamine, which can induce seizure. That's also a main problem. Next question, please. What about the safety of second generation antihistamine? Dijo, there are a lot of second generation antihistamines are generally safe.
Yes, sir. Sir, like you rightly said, we have enough and more data, meta-analysis, review telling us majority of the second generation antihistamines are very safe in children. You have cetirizine, loratadine, levocetirizine, desloratadine, fexofenadine, new one is rupatadine, and even ibastamine. All of them have a similar safety profile, of which cetirizine is licensed for 6 months to 2 years of age, so you can give it quite early. Even though we feel it causes sedation, it causes only around 2 to 4% of children have sedation. Compared to that, other drugs doesn't show that much sedation also. Even the cardiovascular safety is well established because we tend to use it, all these antihistamines at a much more higher doses in conditions like chronic urticaria. Over there also we understand that we even at a higher dose also, all these have a very good safety profile. Now, when we are careful, what we have to be careful about is very young infant and also about drug interactions. But in general, they are quite safe. Next slide, please, ma'am. Next slide, please, ma'am. Okay, so this is one slide giving all the antihistamines. I've also added another drug which we'll be talking in the coming slides. But in general, if you look at cetirizine is from 6 months, 2 years. Fexofenadine, I haven't gotten this, but fexofenadine usual recommendation is 2 years. But there is a provisional recommendation to use fexofenadine above 6 months in children with chronic urticaria also. So that is one way which you can use, but the core thing which we all have to understand is not all colds require an antihistamine. If it is a viral respiratory infection, the cold, even if it unless a child has allergic rhinitis or is an atopic child, only 30% of children will be feeling better because a child got an antihistamine. Majority will feel better by clearing the secretions from the nose. Over to you, sir.
Okay, I think if you go through these slides, you can see one most important thing. The most important thing is that there are antihistamines are not recommended in children less than 6 months. See, almost all drugs are recommended above 6 months. This is why, because the allergic disorders are very rare in less than 6 months. The only allergic disorder that we see in children 6 months is only atopic dermatitis, eczema. Eczema also, the drug of choice is not antihistamines. You give a moisturizing cream and steroid cream will take over. So below 6 months, no antihistamines. I have seen even newborn being given a combination of chlorpheniramine drops for even newborns also. We can definitely induce seizure in a newborn. Below 6 months, no antihistamines, even first generation or second generation. Above 6 months, you can give second generation. And fexofenadine can also, now the recommendation is that you can give fexofenadine above 2 years. Thank you. Bindusha, what is the safety of dextromethorphan? This is a common cough suppressant that we see. Most of the more cough suppressants than is dextromethorphan. Is it safe or not safe?
Dextromethorphan, because even if it is considered as an antitussive, what we need to know is that it is not just an antitussive. It has multiple effects. It blocks the NMDA receptors, since it can produce hallucinations, euphoria, agitations and all. It also binds the serotonin receptor, so patient can have serotonin syndrome in higher doses, especially if the child is on other drugs which will inhibit the MAO. Patient have seizures, muscle rigidity. Then it also blocks the reuptake of peripheral adrenergic neurotransmitters, which can lead on to hypertension, tachycardia, mydriasis, and diaphoresis. And it also binds the sigma opioid receptors, through which it has the antitussive action. So since it has all these effects, the safety of this drug in children below 4 years is not established. So it is not recommended for children less than 4 years.
See, the thing is that dextromethorphan, the main problem is lot of side effects are there, but it's very important to give the correct dose. The dose of the drug should be very correct. Up to 6 months, the maximum dose is 30. 6 months to 12 months, it is 60. Above that, it is 120 milligrams. So must give the correct dose. If the dose exceeds the pharmacological dose, they can have lot of problems. Next question. Yes, Cam. Are cough syrups needed for children less than 2 years? We were all talking, and the government of India has put an order saying that cough syrup should not be given for children less than 2 years.
Yes,
What is
sir.
your opinion?
Yes, sir. This is another
You support or not
another
support?
controversial question. So we have to discuss it in terms of the efficacy, the safety, and the pharmacology of this thing. So from time immemorial, conventionally, most of the majority of us will be maybe using some drug other than paracetamol for even a common cold. But as per the available evidence, there is no proven benefit over placebo. Any cough syrup is not having any proven benefit over placebo in the RCTs. There is one Cochrane database of systematic reviews, which was published in 2014, which definitely proved this statement. And coming to the safety also, that is also a very important thing. There is a high risk of toxicity like sedation, arrhythmias, convulsions, especially with the multi-ingredient syrups. And another important point is that most of the ingredients, including the expectorants or decongestants or antihistamines, they are lacking the pediatric dosing data below 2 years. So even antihistamines, as Sukumaran sir rightly mentioned, less than 2 years as of now, we do not have any antihistamine which can be used below that age group. So the regulatory alerts in the Western population, the US FDA and the UK MHRA, they contraindicate the use in less than 2 years, and the over-the-counter medications, they are discouraging the use in less than 6 years. So as of now, the government also have come with a directive that we should not use prescribe a cough syrup in this age group. So personally, I feel that is a right decision and we are supposed to follow that.
So, thank you, Krishna Mohan. Now to all panelists, what is your opinion about the government order saying that cough syrup should not be given for children less than 2 months? Jijo,
Sir,
comments?
considering the number of irrational medicines which is available in the market, and the parents can go and ask a pharmacist, what should I give my child for cough today? And the pharmacist can issue it, and the parent can just buy it and or repeat the same prescription which a pediatrician has given for another indication. Over there, in that scenario, it is always safer to say not to give. That will be one. But in specific conditions, if the child has seen a pediatrician and the doctor's prescriptions very clearly and everything else is there from a hospital from such a similar setup, I would say in very specific conditions you can consider, but always only monotherapy and not a combination, and always for an extremely short duration with counseling for all the other possible complications to the parent.
Bindusha, what is your opinion?
Sir, I would also like to agree with Dr. Jijo. As a rule, for upper respiratory infection, we need not prescribe any cough syrup. But for specific conditions, like since this should not be a blanket statement as it, but for a specific condition like an allergic rhinitis or something, we should be actually able to prescribe a specific drug for that condition. Even though some people consider them all as cough syrups.
And also those children present with wheezing. Wheezing is very common. In children with an episodic viral wheeze, virus-induced wheeze, you have to give a bronchodilator. Drug of choice will be bronchodilator. Immediately after giving bronchodilator, the cough subsides. So such drugs can be given, definitely given. Even though you can call it as a cough syrup or not, I don't know. Okay. And next question, please. Yes, Jijo, what is the IAP guidelines on cough syrup in children?
So the IAP guidelines is very similar to what we have been talking so far, wherein it also recommends that under efficacy of cough syrups is in generalized, if you're generalizing, it is very minimal, or based on all the data, it is no better than a placebo for an acute cough, which is why none of the guidelines or none of the textbooks will have any recommendation for any of the cough syrups which are widely available. And use in children under 2 years is not recommended. Opioid antitussives, especially codeine, we have to be very careful and it's not recommended. Nowadays, it's not easily available also. Alternative options, primarily supportive care. Honey can be tried. We'll come to honey in the coming slides. But majorly against fixed drug combos, and parental advice becomes very important, because at the end of your OPD, after seeing everything, at the first question the parent is going to come, chomic endo kodukkunnu. Chomic ke marunille. So the important point is to make them understand the cost of the cough, the course of the illness, and when they should be coming back to us with all the red flag signs, which is particular to the particular illness.
Okay, so very good guideline. Thank you. Next slide, please. Bindusha, what is the role of bronchodilators? We are talking about children presenting with cough. I think the commonest cause of cough in a child is again an asthma, or this is an airway disease. They present with a recurrent episodes of severe persistent cough around early morning hours. What is the role of bronchodilators there?
Bronchodilators can be given if the child is having bronchospasm. Any child who is having bronchospasm, as Sir said, asthma is the most common cause for children coming to us with cough. Other than the upper respiratory infection, asthma is the one that we usually see. In those conditions, and also when the child is coming to us with viral induced wheezing, bronchopneumonia with wheeze, where all there is an element of bronchospasm. In those conditions, we can give them bronchodilators. But in the case of asthma and all, where you have inhaler drugs, we prefer to give inhaler than the oral medicine. But if it is just a pneumonia with wheeze, where you are not expecting the child to come to us again with wheeze and all, we may even be able to give oral bronchodilators also.
Bindusha, one more question. There are a lot of bronchodilators there. You can have salbutamol, levosalbutamol, terbutaline. Which will you prefer?
Salbutamol is the one that we usually give. Why? Because it is widely available and that has the clinical efficacy also. Levosalbutamol is actually less efficacious than salbutamol, even though the tachycardic response is less, the efficacy is also lesser.
Let's see, salbutamol, we are giving half the dose.
Half the dose.
The effect is less,
Yeah.
but the effect is also half.
Effect is also less.
What is your opinion regarding? See, you are saying that it should not be given for children less than 6 years. Salbutamol is not very effective in children less than 6 years.
6
What is
years.
your opinion, Lilo?
Sir, if you look at the FDA guidance, what they have told is above 4 years is what salbutamol has been recommended even as an MDI, and as a debilization solution also it will be above 6 years is what the data is. Wherein before that there is no strong indication to use salbutamol. And in fact, like sir has earlier told also in asthma and any of your GINA guidelines, there is nowhere salbutamol will replace salbutamol in either status asthmaticus or any condition. So given that the first line of choice will always be salbutamol, and levosalbutamol you will use it very sparingly, even though levosalbutamol is more easily available in the market and it's actually much more expensive than your plain salbutamol also.
What about terbutaline? Terbutaline syrups are available, lot of.
You can use it, sir, but I don't have much experience personally using it. So whatever I have had experience, it has been with just regular salbutamol, and the effect is what you expect is you can get it. But like is always told, it is not what will be your core treatment for asthma. It will always be your inhaled medications. This is only for a short term, or maybe for an intermittent visa, where the parents are not very willing and they want to attempt an oral medication.
So I think that the preferred drug should be either salbutamol or terbutaline rather than levosalbutamol. Levosalbutamol is
Yes.
not very effective. Not very effective.
Salbutamol is costly also. The cost
Yeah.
also is almost
Ah,
double.
Costly
double
also.
cost.
See, one terbutaline syrup costs more than 100 rupees, 120. Terbutaline syrup, 120 rupees. But Astanin cost only 20 rupees. Such price difference is there.
Actually, when the salbutamol came under the price control, almost all the companies actually shifted to either levosalbutamol or terbutaline so that they
Ah.
can
That is
charge
also-
more. That is also.
That is why a lot of levosalbutamol preparation is available in the market now. Next slide, please. What is the role of mucolytics? Most of the cough syrups contains mucolytics. Will you do this or not?
Yeah, so mucolytics is also another drug which is most often misused or irrationally prescribed, especially in the less than 2 years of age. So we have the ambroxol, bromhexine, acetylcysteine, and carbocysteine. These are the major mucolytics we have. But if we check the limit, the age limit which is recommended, the lower age limit, it is recommended only from the 2 years and above in all these 4 mucolytics. And the basic mechanism of action is that it makes the phlegm thinner and less sticky. And there is another entity which is described, which is called as paradoxical congestion. That is especially in the less than 2-year-old kids, if you use a mucolytic, there is a chance that the mucus may become thinny and less sticky, and there is a chance of aspiration. So that is what is called the paradoxical congestion. So majority of the international guidelines are against using mucolytics in less than 2 years. So, but unfortunately in India, we have formulations including plain ambroxol, which is supposed to be used in less than 2 years. There are ambroxol drops also, but scientifically, if you are thinking, it is not supposed to be used. So basically, mucolytics are meant for chronic lung conditions like bronchiectasis and cystic fibrosis, not for a simple upper respiratory infection, or in our day-to-day practice, we are not supposed to use that.
Thank you, Krishna Mohan. The most important point is it should not be given for children less than 2 years. Not below 2 years. What? We are giving mucolytics even for the newborn. Mucolytic drops are available. It is being lavishly given for newborn also. So the younger stage is 2 years. So for all drugs, not only for mucolytics, all antihistamines, all bronchodilators, you must know the younger stage at which you can prescribe these drugs. That is very important. Thank you. Yes, Bindusha, next slide. What about the Levodropropizine? This is a very complicated name.
Yes, sir. So, yes, we took this drug because this was asked in one of the forums as to what is the current evidence regarding this. Before we come back, even oral salbutamol, the clearance is only for children above 2 years to use it at a dose of 0.1 ml per kg 8th hourly. That is something which what the recommendation is. And up to 6 years, you are not supposed to exceed more than 4 milligram 8th hourly when you're using salbutamol. So that is roughly 10 ml 3 times a day is your upper limit for salbutamol, which you can give safely. But there are many people who actually use salbutamol in smaller children also. the risk for the oral medications is the adverse effect possibility is always higher. But salbutamol as a medicine, as a molecule, is something which all of us use, even smaller children as nebulizers as or as inhalers. In for example, if you have an asthmatic child who's coming at 1.5 years, multiple viral episodes, all those ages we have been using it. So in that aspect, this is something which you can consider. Coming to this drug, the next slide. This is not something which I've used, but I've been going through the evidence, and this is what we could find. This is a newer drug which has been there, which is it's not a new drug, but it has been available recently in the market, which is a peripherally acting antitussive drug. It has been shown to have statistical significance, not necessarily a clinical significance, but statistical significance in efficacy in reducing cough frequency, severity, nocturnal awakenings when compared to central antitussives like codeine and dextromethorphan. So we have enough data to show in upper respiratory tract infection and bronchitis, in general, better overall antitussive effect and benefit risk profile when compared to the other medicine. Now, it is effective as before with a lower. It has a lower incidence of daytime somnolence, better tolerability. Majority of adverse effects are generally mild, making it a safe option in cough management. But we will come to the next slide as to what the further details are. The other drug, levocloperestin pensidoiode, it doesn't have enough data at this point to be recommended for children. Not enough data to talk about what are the possible side effects also. Coming to the next slide, it's a single slide. At this point, it is approved for children about 2 years of age. Generally contraindicated or not recommended under 2 because of sufficient data, sufficient safety data possibility, and potential risk is also always there. Dosage is going to be 1 mg per kg per dose, max 3 times a day, with a maximum of 3 mg per kg. Duration to be limited up to 7 days. Do not give it beyond 7 days. Age group is 2 to 14 years. Available strength is 30 milligram in 5 ml. But again, it has to be cautioned, especially if you're using in children who have hepatic or renal impairment. This is what the current status is about this drug.
See, Joe, thank you. But I want to confirm one thing about salbutamol. Salbutamol, we previously thought that it was not effective in infancy. But it is found that these bronchial smooth muscles are well developed even up to after 28 months of intrauterine life. Every time babies have got a smooth muscles are well done. I think so. Salbutamol may be effective in younger age children also. May be effective.
So the salbutamol as a molecule is definitely going to act in smaller children also. But because the chances of a toxicity or adverse events will be higher when you're using an oral medication versus it in a nebulized form or as a MDI form. That's all.
Next question, please. Next question. Vindusha, you can talk about glycerol in cough syrup. This is a common component in cough syrup.
Glycerol is a common component in many of the cough syrup. It was actually originally used as the diluent in the cough syrup, but it does have different actions. Glycerol has lubricating action, so that it will actually prevent this irritation in the throat, especially when the tongue and the pharynx are moving. And it has demulcent action, which so that it has a soothing effect on the irritated pharynx. Then due to the sweetness itself, it has a sweet warm taste that also will decrease the coughing reflex, and also it has humectant action where it will retain the moisture in the throat and all. So due to these multiple actions, the glycerol itself will have some effect on the cough. It is said that around 85% of the effect in the cough syrups is actually due to the glycerol itself and not due to the active content in the cough syrups.
Next question. Oh, regarding honey in cough. Dr. Juja was also talking about honey previously. Bindusha, what is the role of honey? Can we give honey?
Honey
And what
is
is the
also
dose?
a demulcent. Honey is also a demulcent, so it has an effect on the cough. Especially, it will also will have a soothing effect on the pharynx, and it will relieve some of the, especially the dry irritant cough may be relieved by the honey. There are different studies, especially Cochrane reviews are there, which has reviewed 2 RCTs, which was done on 265 patients, and they actually compare different arms of the study, where actually patients who were on no treatment at all, patients on honey, and patients on antihistamines and dextromethorphan. What they found was that honey was better than either placebo or no treatment, and also diphenhydramine, and the effect is actually similar to the dextromethorphan. So honey is something that we can use for the viral upper respiratory infection, which is leading on to the cough. But it has some safety issues, especially in infants, because it may be contaminated with Clostridium botulinum and can lead on to botulism. So it is advisable that we use only pasteurized honey so that this contamination can be avoided. And honey is recommended also only in children above at least 1 year, maybe around after 2 years we can safely give honey. It is recommended at a dose of 2.5 ml, maybe at bedtime, or 1 or 2 times a day may be given to relieve the irritant cough.
Thank you, Binusha. Even WHO recommends honey
Yes.
as a home remedy
Yes.
in children, and that about 2 years, 2.5 ml in children about 2 years. That's right. KM, what is the timing of cough for etiological diagnosis that we usually see?
Yeah. So the time when the cough occurs most. Next slide, madam. Okay.
You are not well audible, Krishna.
Not audible, sir. Now.
Better.
Okay. So the timing of the cough is very important. It will give us a clue regarding what is the etiology of the cough. For example, in an asthma, it is mostly nocturnal. And if it is a postnasal drip, a cough which starts immediately after lying down or when the patient goes into the supine, it is a pointed towards a postnasal drip. And asthma, as I already told, it can occur also in the early hours of the morning. And when it is occurring after feeds in the lying down position, it is can be a clue towards an underlying GERD. And a cough which is getting worse in the evening, especially in the evening after the exposure to the irritants and the pollution, it can be due to some hyperreactive airway disease. And it can also be due to asthma. If it is an exercise-induced asthma, it can occur soon after exercise. And another important entity is the habitual cough or the psychogenic cough, which is typically absent during sleep. So that is also very common nowadays, especially in the adolescent patients. So that also we have to keep in mind.
See, one more point I want to highlight is again that if a child is presented with a persistent cough around 2 a.m., 3 a.m., 4 a.m., if you give a salbutamol MDI, salbutamol syrup, the child responds, it is definitely asthma. Then other problem is a child who's gone coughing during that time, while awake and disappears during sleep. Definitely it is an psychogenic cough. That's right. Jito, what is the difference between viruses and cough duration? Viral infection cough duration.
Yes, sir. Before I just answer this, I'll just add a few points to the honey which we already discussed. Now, the problem with honey is majority of the recent study which they have done, they've shown us majority of the honey which is available in the market doesn't actually have honey in it. It is a sugar syrup which is available. Now, even the sugar syrup might or might not help a child. So I won't be surprised in the coming months we will have a pharmaceutical company which is going to come out with WHO approved honey, which is in a smaller bottle, which is pasteurized to be used only for cough. So that is going to be something which we will have to see. But so many times when we say it is honey, it need not be honey what is actually available in the market. Now coming to the viral causes, it is very important to understand what virus is circulating in a particular season, because as per the virus, the cough also might change. For example, if it's a rhino or a coronavirus, the cough. So instead of just saying it is a viral cough, if you are understanding what is the etiology and what is happening around you, you will be able to counsel the child better. Because for a coronavirus or a rhinovirus in children, it was going to last around a minimum of 5 days up to 2 weeks. Majority get better by the end of 2 weeks. 50% of children stop by around 10 days. 90% will stop by up to 3 weeks. And around 10% beyond 3 weeks also it can extend, but rarely complications are seen and they resolve naturally. Irrespective, you give any syrup, cough syrups at this point, it is going to take its own course to get relief completely. If you have an RSV, the usual trend which is happening right now. Majority of the viruses which we are isolating at this point is RSV. So we have a minor RSV epidemic going across the state. So it will last between 1 to 2 weeks, with infants and high-risk children having longer symptoms, up to 4 weeks. So in infants, smaller babies, the RSV can be very detrimental. It will take quite a long time, including IP admission, a very long time for the cough to completely get better. Pertussis, like we all know, is a 100-day cough. So once pertussis starts, you will need your central antidepressives to give some relief to the child as the child tides over the duration. But because of vaccination, it is coming down. But at this point, we tend to see it in adolescents and bigger children. The viral infection, classically, your influenza, parainfluenza, adeno, metapneumo might take up to 3 weeks, but all these ones has a higher risk of having a secondary bacterial infection. Now, any point, if the cough goes beyond 3 to 4 weeks, it has to be, you have to make sure it is not a bacterial bronchitis, pertussis, or other underlying causes which is causing the cough to go on. Over to you, sir.
Riaz, how much time you can take now? Riaz is there. How much time?
Hello,
Completed.
sir. Sir, it's almost 9:15.
Yeah.
Can we finish in 10 more minutes?
Okay, okay. I
It
think
will be
there
over, sir.
are
It will be
lot of
over in 10
questions
minutes.
in the
It will
chat
be over.
box. Krishna Mohan and all, there are a lot of questions in the chat box. I think we have to take it up. Next slide. Next question. Next question. This is regulatory and manufacturing standards. Why gaps occur in India and not in other countries? How to rectify them?
Okay, so next slide, please. So we have the regulations available in our country, but there are definitely some major gaps. That is why complications like these are occurring. And we will be discussing what are the regulations, what are the gaps, and how to fix them. So basically, this is regulated under the Drugs and Cosmetic Act, which is what is called as the Schedule M for GMP. GMP means good manufacturing practices compliance. That is what is required. So this is surveillance is done by the CDSCO, the central authority, as well as with the state drug controllers. But definitely there are some major gaps that may be due to some inconsistent surveillance. So maybe due to some poor raw material, maybe due to adulteration, all these things may be resulting. But the basic thing to be done for the fixing these things is that the law should be more strict. There should be strict enforcement of the revised Schedule M. And if anybody is not working as per this rule, they should be their license should be cancelled. But as doctors, the only thing that we can do is just to follow the available guidelines. That is, we have to stop all the irrational prescriptions. As Dr. Jejo mentioned in the beginning, we are having a lot of irrational combinations. So our duty and our responsibility as doctors is to follow the guidelines and stop prescribing any of the irrational combinations. That is it, sir.
Next question. What is the expert opinion regarding what happens in Madhya Pradesh and other places? Dijo, what is your opinion?
Sir, we spoke about it earlier. It is still the same point. It is, first and foremost, it is, as we all know from all the previous experiences, I don't think it is the molecule which has caused, it is most likely the contaminant which has caused, because when we look at dextromethorphan, the side effects doesn't have the classical presentation which the children presented, and further death happened. It's very unfortunate that the doctor got arrested for something which is absolutely not in his control, which is contamination which is happening at the company level. And as we all know, even today there was an attack on a doctor which was there for a patient whom he has not even seen. So it becomes very unfair upon a doctor and everyone who's practicing when such things happen, and the law of the land, neither the people of the land stays with the person who is treating the patient with absolutely no bad intentions at all, sir. So the law has to be much more stringent in punishing the people who are actually responsible. And like rightly said, the one good thing which has come out is from this is no child, hopefully in Kerala, will get any medicines over the counter without a doctor's prescription. And as long as the pediatrician is seeing the child regularly, we will be able to prevent and cure most of the illnesses which come in.
I think we will wind up and we will take up questions from the chat box. Before that, I just want to ask this one question.
Sir, I would like our incoming President Nandakumar sir to chair the discussion session. He is also the President of the respiratory chapter. Over to Nandakumar.
Nandakumar, please come. And you can take up questions. And one more question I will ask the panelists. One point we had not discussed is almost all guidelines, they say that steam inhalation is found to be effective for cough. What is your opinion? Steam inhalation and cough.
Sir, the data has been very mixed, sir. So in children, majority of the whatever more than the benefit, all of us have seen cases of scald burnings coming in with children who have been taking steam inhalation. So that is the biggest risk. So more than the minimal benefit, the chances of a scald injury is very high. So a normal saline in itself will clear most of the secretion and work as good as a steam inhalation is what I believe, sir.
See, Jijo, what I want to say is that there's a very good article in one of the PCNAs which came earlier. They say that steam inhalation is not going to be effective. The only thing that, as you said, is it can produce scalds and this is not beneficial. But some of the guidelines say that steam inhalation is found to be effective in treatment of
The ENT people prefer steam inhalation for most of the causes and they tend to write
But
it.
we have seen a lot of children coming back with scalds.
Yes, sir. Yes, sir.
Burns.
Yes, sir.
Okay. Can you take up the...
So, yeah.
Oh, Nandu?
Sir, thank you, Sukumaran sir, and Dr. Bindu Shah, KM, and Dr. Jijo for that excellent discussion on these current issues which almost all doctors, especially pediatricians, are facing in our day-to-day practice. Because nowadays, if you write a cough syrup or if you write a bronchodilator, immediately the patient will ask, Doctor, kodukam vanda. And otherwise, they will ask to medical shop. So I really like what Krishna Mohan concluded, because be rational. That is the one thing we can do. Be know about what you are writing. That is one of the most important. For which condition you are writing that, prescribing that drug, and you have to be very clear. And you have to be you should able to explain to the bystanders why I am writing this drug and what are the contents, what are the side effects of this drug. And as far as possible, use standard companies. That is another thing we have to do, because we have a lot of, as you all know, we are getting a lot of pressure from pharmaceutical companies about writing of their products. So you decide which is standard drug and prescribe. So since time is running out, we are running out of time. I am going to read a lot of questions.
Questions? We'll take up.
I think a majority of questions Dr. Jijo answered in the chat box itself.
Yeah.
Somebody has asked regarding role of a Budicort nebulization in cough and age cutoff.
Say, questions are the role of Budicort in the treatment of cough. I think the only thing is that Budicort is a very good drug for treatment of acute asthma, persistent asthma. So those children presented with cough as a manifestation of asthma, they'll be beneficial. They'll be benefited. Okay, next question.
Sir, there is another question. What can we give for infant with bronchiolitis for cough?
Many questions on bronchiolitis. It will be better, sir. We can just
Yeah.
conclude it together about bronchiolitis.
Any other questions? See, regarding
bronchiolitis, a lot of questions.
See, regarding treatment of bronchiolitis, because there are a lot of controversies are there for treatment of bronchiolitis. Everything is controversial, except, as you know, oxygenation, maintain the oxygen by 95%. IV fluids, oral fluids can be given. What I want to say is that even some of the books say that you can have a trial of bronchodilator. Especially those children with a family history of asthma or atopy or personal history of atopy with first episode of bronchiolitis, they may respond to salbutamol. The cough may subside with salbutamol. I think the saline nebulization is found to be effective. Hypertonic saline may be effective. You can try hypertonic saline. And also it is very important that you wait for 1 to 2 weeks time. The cough will subside only within 1 to 2 weeks. Whatever drug you give, it will take 1 to 2 weeks.
So what about giving this saline nebulization, nebulization home?
Oh, see, I think even the main problem with saline is when saline can also produce bronchospasm.
Yeah,
Saline can produce bronchospasm. See, for demonstrating mycobacterium, you can induce sputum. In the national guidelines, they say that you must give a salbutamol nebulization before giving hypertonic saline nebulization for sputum induction. So it can also produce problems. So I think nebulization should not be given at home. It should be oxygen driven, even this saline. Questions?
Then
I think most of these questions Jijo has
No.
answered in the chat
Chat
box.
box. Yeah.
No, another question which they asked is, what about second generation antihistamines? Because you already mentioned that first generations and
That
can
also was discussed.
induce convulsion.
Ah,
Yeah.
okay.
So what about because any antihistamine action central action, no doubt, they has got action. So it's a stimulant or it's because it can induce seizure. A child already on seizure or child on febrile
What I
seizure.
say is that those children who gives a history of seizure or here who are giving anticonvulsants, anti-epileptic drugs, definitely you should give any of the antihistamines.
Yeah.
Including
Because
first and
nowadays,
second.
yeah.
And among first and second generation, the seizures are less with second generation. It's relatively the same. But it is better to avoid all antihistamines in children with a history of seizure or a child taking anticonvulsants.
There are multiple questions about home nebulizations.
Yeah.
I think that is also some.
Yes, Krishna Mohan, you can talk on home nebulization. He's the ideal person.
Nebulization we recently discussed in Pedalarcon also last week. So home nebulization is not at all recommended. Even IAP NRC as well as Central IAP is strongly against home nebulization. So what is recommended is that only if it is done in a hospital with an oxygen, it is recommended. But nowadays, some of the parents last week they told they brought oxygen cylinder at home and they started nebulizing. So because they love the ambience created by the nebulization, the sound, smoke, etc. But we should not encourage using home nebulization because, as we know, the basic physiology, there is a chance of ventilation perfusion mismatch if you do it. So, if it is done at home, there is a chance of some adverse effects occurring. So, it should not be encouraged.
Shravan, and also MDI is equally effective as nebulization for treatment of mild moderate exacerbation. So you start with MDI, salbutamol MDI. Children up to 6 months, 6 years, you can give 6 puffs, and above 6 years, you can give up to 12 puffs. This is equally effective. Then ventilation perfusion mismatch is less with MDI. Then why you go for nebulization? But people like nebulization. I don't know.
I think the discussion is going away from the cough. Now we are discussing about the asthma. So we want to reach a conclusion and everything here because asthma is a very long subject and there are controversies there. So what we have to reach in a conclusion, that is I think more important than going on discussion on nebulization and some things. It will come and
these are the questions asked by the audience.
Because such a question is not, and because here we have to get a guidelines because DM is there, DHS here, everybody is here for getting a conclusion for cough syrup and cough remedies. I think.
So after this discussion, now I invite Dr. Riaz to give the final opinion and recommendation by Indian Academy of Pediatrics on cough syrups and management of cough. Dr. Riaz, please.
Thank you, sir, and the co-panelists for clearing most of the doubts. And I think now the group has a clear-cut idea of what to give. So one point which has been made clear is we can treat cough in children with the appropriate medicines when indicated. And remember, acute cough most of the time disappears without any treatment. And we should not go for any irrational combinations, FDCs, and we should all make sure our practice has to improve. And also another point is we have to ask the government to make the regulations very strict so that such mishaps should not happen in the future. I request the same group to give a written document also which we can submit to the government as a part of our activity. Thank you once again.
So I think we can conclude. Yes, we can conclude now. I think the decision taken by the national body is a correct decision. No cough syrups in children less than 2 years. That's the best decision. Then cough should be treated as a symptom. As a symptom, you should not treat. You must try to find out the etiology of cough and use specific drug for treatment of cough in children. And also, regarding antihistamines also, you should not use multiple antihistamines. Ideally, you should use only single drug as far as possible. Thank you.
Thank you, sir. Thank you,
Yeah.
everyone.
Okay, we'll wind up.
Thank you, sir.
Thank you very much.
Thank you. Thank you.
Okay.
Thank you. Good night.
Bye.
Thank you. Thank you. Good night.
Thank you.
Thank you.